Hello and welcome to Meet the Author. I'm today's host Ali. I'm also the managing editor of Arthroplasty. Meet the Author is a regular column of Arthroplasty, the official journal of Asia. In this column, we will talk with different authors about their scientific life and clinical career, as well as their ideas on publication, especially in our journal Arthroplasty. They will lead us into the world of orthopedics with their professional vision and successful work experience. Let's go! Today, we are going to talk about leg length discrepancy after total hip arthroplasty with Dr. Seiya Ishii. He's now working and studying at Gentendo University Hospital in Tokyo, specializing in treatment of degenerative hip joint disease. Now it's time to welcome Dr. Seiya Ishii. As a young doctor and researcher, today he's also waiting to talk about how he puts effort into self-growth and the way to overcome difficulty in work. Hi, Dr. Ishii. Thank you for joining us.
Thank you for introducing me to this program. I'm very honored to be here today.
Thank you for your time, Dr. Ishii. Your contribution and support to arthroplasty are greatly appreciated. The complication of dislocation in total hip arthroplasty postoperative is a common problem that each doctor has to face. Recurrent dislocation results in residual pain and contracture of the hip joint, decreasing the patient's functional skill and quality of life. The dual mobility cap was developed and could be used because of its resistance to postoperative dislocation. Your article, Does Total Hip Arthroplasty with a direct anterior approach using dual mobility increase leg length discrepancy compared with single mobility, published in our journal, come up with your exploration on leg length discrepancy measurement by dual mobility cap. First of all, could you please briefly introduce your article?
At our institution, we perform DHA through direct anterior approach using fluoroscopy, and we have achieved a very low dislocation rate combined with the use of dual mobility system. However, we have experienced that it is very difficult to dislocate when we perform reduction using dual mobility head because soft tissue tension is high in the direct anterior approach. Therefore, we use a short offset of 32 mm trial head for trial reduction phase and evaluate the leg length fluoroscopically. However, it is difficult to evaluate the leg length accurately because the final leg length with the dual mobility outer polyethylene becomes longer than that of the provisional reduction using 32 mm head. So we investigated the differences of leg length discrepancy between dual mobility DHA and single mobility DHA. As a result, there were no differences of leg length discrepancy between the two groups. This is the first report that presents limited risk of leg length discrepancy after DHA using dual mobility system, and we believe dual mobility system is a safe implant that have limited complication and decreased dislocation rate.
Thank you for giving us an overview of your article. Now let's look into it more specifically. In order to better understand the significance of your research, would you like to explain some of the keywords, such as characteristics and indications of dual mobility cap?
Dual mobility cap have high oscillation angle and jumping distance. This character enables to decrease dislocation risk. However, there are not enough evidence of long-term survivorship and concern of long-term cobalt ion release from cobalt chromium liner in dual mobility system. We restrict the indication of dual mobility system that patients aged over 70 years old and over 65 years old who have high risk of dislocation.
Thank you for the detailed explanation. The dual mobility cap can help to decrease dislocation, but it's not perfect in long-term safety in human body is unclear. Despite the increased use of dual mobility caps, high-quality evidence of their effectiveness is lacking. In long-term cobalt eye release is also need to consider. You mentioned that it's difficult to achieve per-vision reduction when you use dual mobility trial head. Could you please share with us about the method to assess the leg length in the operative protocol of reduction or dislocation phase?
We estimate leg length using fluoroscopy in trial phase, and we always use 32 mm conventional trial head for that, although in case of dual mobility too, because we experienced highly difficult to dislocate using dual mobility trial head in trial phase in the past. The extended length using dual mobility implants compares to single mobility 32 mm trial head is calculated corresponding to cup diameter. For example, 50 or 52 mm cup diameter correspond to 42 mm dual mobility polyethylene outer head. And extended length to body axis is 3 mm if the single mobility 32 trial head is used. Similarly, the extended length to body axis using 54 or 56 mm cup is calculated 4.2 mm. The calculation chart of extended length between 32 mm trial head and dual mobility system corresponding to each cup diameter is printed and posted on the wall of the operating room.
It's a great idea to post the calculation chart on the wall of the operating room. Moreover, according to your research, the risk of LLD was no higher than that with a SM cap, and the superiority of the DAA and DMC has a positive synergistic effect on resistance to dislocate without increasing the risk of complications. Therefore, what are the advantages of dual mobility cap compared to single mobility, and what are the disadvantages?
The major advantage of dual mobility is to decrease dislocation rate. Systematic review at 2030 revealed THA with dual mobility have 4 times lower rate of revision surgery due to dislocation compared to single mobility THA. As a disadvantage, corrosion and cobalt ion release from cobalt premium liner and idiopsis impingement are previously reported. However, in our hospital, we checked the level of blood cobalt ion for patients with dual mobility cap 7 years after surgery. All of the patients demonstrated safe level of blood cobalt concentration. Our indication for dual mobility that basically patients over 70 years old might reduce mechanical stress for implant. At least, dual mobility for all patients could be a safe choice with low risk of systemic cobalt ion complication. There was a concern that the double-sided surface would increase the amount of wear on the polyethylene and require early revision surgery, but good long-term results have been reported with the use of highly cross-linked polyethylene. In the dual mobility system, almost only the small inner head moves in daily normal life, and the outer polyethylene only moves when it is about to be dislocated. Past investigation in vitro revealed less polyethylene wear of the small diameter head than that of large diameter head. I think polyethylene wear of the dual mobility system is not a problem.
Even though there are disadvantages reported, with your research and follow-ups, The theoretical issues nearly have not appeared in clinical trials. That's a good thing. And based on your findings, do you have any suggestions or tips for surgeons to apply your method of THA intraoperatively?
We believe direct anterior approach using fluoroscopy reduce risk of leg length discrepancy and implant malposition. Although we use leg positioner for direct anterior approach during surgery, it is also easy to perform same THA using traction table for proximal femoral fracture. This is similar to perform internal fixation surgery for proximal femoral fracture using fluoroscopy. It could be easy to introduce for many surgeons who got used to internal fixation for femoral fracture.
Thank you for the information. I would assume that our audience should have taken that into future operations. Then about the dislocation, why does DAA dislocate and what are the factors in which influence the dislocation rate? Would you like to explain those for us, please?
I think complex factors are combined and induce dislocation. The major factor will be the state of soft tissue. Preserved muscle and joint capsule maintain tension enough to prevent dislocation. And direct anterior approach will be the optimal method. Not cutting muscle, maintain soft tissue tension. And we preserve anterior joint capsule as much as possible and suture tightening for cases with high risk of dislocation. Still, there are cases of anterior dislocation after THA, although direct anterior approach and cup positioning angle within the safe zone. In such cases, we believe that pelvic mobility during postural change is reduced. Posterior impingement in the standing position and anterior dislocation will be induced. In recent years, this abnormal pelvic mobility has focused on an independent risk factor of dislocation. And there are investigations that the amount of change in sacral slope between standing and sitting position, as well as PI-LL mismatch, is a factor of dislocation risk. In order to evaluate the pelvic mobility, we have introduced the EOS system in our hospital. And in cases at high risk of dislocation, we consider to use dual mobility and place the cup in reduced cup anteversion.
I understand that it's quite essential to have your research done. So are you planning to do any further research to optimize the results and the conclusion of your current research? What are the next steps?
In first place, to minimize the so-called anatomical leg length discrepancy, which evaluates leg length by comparing the position of left and right lesser trochanter, does not necessarily improve perceived leg length discrepancy. And appropriate amount of leg extension is unclear. Hip joint disease in the developmental stage, such as perotus, is reported to cause differences in female legs. In addition, in some cases, post-operative pelvic obliquity gets worse after THA by overstraining of the abductor muscle due to leg extension with THA. That causes post-operative abduction contracture on the affected side. Further investigation about method of accurate assessment of pre- and post-operative total leg length and estimation of abduction contracture before THA will achieve less subjective leg length discrepancy.
Further investigation can always give us the opportunities to optimize our findings, and we are looking forward to hearing more about leg length discrepancy. Scientific research is a wonderful journey full of discoveries and surprises. Along the way, it's also covered with thorns. Referring to your research work, What was the most difficult things you have faced? And how did you solve these problems afterwards?
The moment I discover the causal phenomenon that I have been wondering is very exciting. However, the process of presenting that discovery to the world as objective data using scientific method is a very long and persistent process. There may be no easy solution for this part of the process. I think the most important thing is to always keep going, just like running marathon.
Wow. So after the researchers come up with a way to present their discoveries to the world using scientific methods, how to transform the scientific research achievements into papers and publish them efficiently in academic journals is a problem that many researchers need to face. And it's also the important way in the process of personal academic development. Do you mind sharing with us your method in paper writing? How do you choose topics, write papers, and then publish it?
In order to come up with a great idea, we need to understand the current problem and spend a lot of time in trial and error. To write papers and publish it also needs a lot of energy. If the researcher have a deep interest in the field, academic achievement will be naturally maximized. Choosing the topic that the researcher truly interested in is the best way to promote the achievement.
I agree with you. I believe the researchers and authors who choose to publish their achievements in our journal should all have that driving forces. May I ask, how do you think about our journal Arthroplasty? At what moment you heard about this journal and decided to contribute to it?
As a doctor in Asia, specializing in joint prosthetics, I am very happy to see the launch of a journal like Arthroplasty that will bring innovation to Asia. Asians have different bone morphology from Europeans and also have different cause of THA, such as acetabular dysplasia. However, implants and surgical methods are often discussed using common concepts around the world. And there is a need for a forum for discussion specific to Asia. A doctor of my acquaintance introduced me to here, and I'd like to keep to be a part of the active discussion in Asia.
Thank you for taking the Asia into consideration, and we greatly appreciate your support. Now, I have a specific question for you. As a young orthopedic surgeon and researcher, how do you improve yourself?
Growth does not exist without experience. So I believe that spending our younger years in a hospital where we can experience as much surgery and research as possible is a shortcut to growth. In addition, to shorten the learning curve, it is helpful to communicate with the senior surgeon in detail about the criteria to be used during the surgery, before and after the surgery. Before surgery, in which I do not have a lot of experience, I used to have wrote down the detail of the criteria for decision making during the surgery in writing before the operation and have the senior surgeon check if to correct any discrepancy in perception.
It's so true that growth does not exist without experience. And learning from senior surgeons is always a great idea to increase the growth speed. And do you think there is any difference between orthopedics and other departments? Or what are the characteristics as being an orthopedic surgeon, especially for young people? Do you have any good suggestions for young doctors like you to grow up quickly in the orthopedic department?
Compared to other surgeons in Japan, orthopedic surgeons are allowed to be involved in surgery from early stage. I think that can assist to maintain motivation. By training at many facilities, we can broaden our skill. And if we could find a doctor who is ideal to be, working in the same group at an early stage will accelerate our growth. As a way to experience this is one of a reasonable way to consider studying abroad at an early stage if we could.
You must have a very good time when you were learning at different facilities. During these years, do you have any impressive patients or impressive symptoms in progression of the disease?
The case that I have greatest impression these days is a patient who underwent DHA for femoral trochanter fracture. The fracture type was severe comminuted and aged over 90. And if we choose internal fixation for this patient, the start of loading will be delayed and she would hardly get work again. She was able to live at home with the support of her family and wanted to continue that lifestyle instead of living in a facility. I chose a new approach previously reported by Canton in France, which allows us to open the trochanter fracture to anterior and posterior in the lateral position and remove the head of the femur and perform THA. The joint capsule is cut only through a lateral longitudinal incision, preserving the anterior and posterior soft tissue. In addition, after implant placement, osteosynthesis of the greater trochanter can be achieved using cable. The patient could start rehabilitation with full loaded day after the surgery. She is leaving her home almost the same as before the surgery.
I'm so glad to hear that. You must have put a lot of efforts in that case. Patient satisfaction is also a significant factor to measure a doctor's profession. The young doctors are now the backbones within the medical field. During the time of your study, research, and clinical experience, I would assume that a lot of mentors and doctors give you instruction and guidance. Would you like to express your appreciations to them through our column?
I have worked at many facilities and have been mentored by many doctors. I think all of my growth has been thanks to the mentor who give me the guidance every day. I also think that the time I spend with my fellow doctor is really precious treasure in my life. As we share the joy of being able to provide excellent treatment in the process and also struggle together if the treatment process is not going well. I'd like to appreciate again my mentors, the people I work with in the hospital, and the researchers of the past who built modern orthopedics.
We also give our appreciations to the senior surgeons who dedicate themselves into the orthopedic profession. Then how about yourself? Do you currently have any expectation or designs for yourself 10 years from now?
Until now, I have only been desperately pursuing my immediate interest, so I have not had firm policy. What I know for sure is that I want to be involved in orthopedics. In particular, it would be great to expand my current research and share my ideas with the world to improve the daily lives of patients who cannot currently be saved.
Yes, it's our honor to have you, such an outstanding growing doctor and researcher. Last but not least, let's end up with an interesting question. What would you like if you were given the superpower, and why?
One superpower that I can perform THA so good that all THA patients will immediately know symptoms and even forget that they ever had THA. And due to the development of technology, this may no longer be a superpower in the near future, but a reality. As for the superpower I really want, I am afraid I cannot tell you here.
Oh, I'm so curious about the superpower you really want, Dr. Ishii. But everyone should have the right to keep your own secrets, correct? Well, thank you for sharing this useful information with us.
Thank you for this great opportunity.
Thank you again for your time. That's what we have for this episode of Media Author. Thanks for watching. In the next episode, we will invite another doctor as our guest. Stay tuned for our next exciting episode. See you.
Thank you.